Good morning, everyone, and welcome to a very short lecture. These two conditions, the names are quite long, but the conditions are quite simple and very easy to understand. One is HSP, which is also Henoch purpura, and one is Kawasaki disease. Now, just to tell you, as an overview, these conditions occur or they are classified as vasculitis or vasculitides, like in which there is inflammation of the small vessels. Now, what we are going to discuss is first of all HSP, okay, Henoch purpura. Uh, now, again, I'll be showing you some photographs, okay, uh, by you taking the help of Bing, okay, how it looks like. But just to tell you, or just to introduce, what is the condition is. Basically, HSP can simply be memorized by a triad. It's a triad of uh, palpable purpura, okay, with abdominal pain and arthritis. Okay. Now, guys, remember whenever there is vasculitis in the body, like this, the vessels are inflamed. So, uh, there's a lot of vessels in that tummy, so they give abdominal pain. It can give joint pains, and it can give um, petechias and purpuras, you can say. Okay, to give you a little more overview about this condition, what is HSP now? Basically, HSP is also known as IgA vasculitis. Okay, IgA, immunoglobulin A vasculitis. Now, the thing is, what happens in this one? This one affects the small vessels. Okay, and in the body, basically, the complexes of immunoglobulin A and complement component 3 C3, they get deposited in many small vessels like arterioles and capillaries and venules. So, simply, if you are good in that hypersensitivity reactions, type 1, type 2, type 3, and type 4. So, in type 3, hypersensitivity reaction is the type of reaction in which the complexes are circulating in the body and they get deposited at different parts. So, this is what's going on. So, it's a type 3 hypersensitivity reaction. Okay, so that is what you can say. Um, what is the causative factor of HSP now? If you had that concept of type 3 hypersensitivity reaction, I think you understand what I'm saying, right? And now the important thing is that this HSP, it is most common vasculitis of childhood, okay, and it is twice more common in males than females, okay, and one of the things which is very important and I must write over here, most often you will found a history of upper respiratory tract infection around 1 to 3 weeks before onset of symptoms. Okay, so now guys, there are many conditions like this. For example, I teach you post-streptococcal glomerulonephritis. The same thing occurs. Uh, History of bacterial infection. Before that, in the previous lecture, I was talking about the transient synovitis. Same thing, upper respiratory tract infection, viral. So the same thing. After the upper respiratory tract infection, 1 to 3 weeks before, after, sorry, they will be having the features of HSP. Okay. Now, guys, why? Of course, it's immunity related. The complexes are circulating in the blood. It is not well understood. Okay, so now the thing is that uh, these are the features, these are the things. This is the clinical triad, and I will show you now. Now you can see the skin. There is small vessels are inflamed and they are having this palpable purpura mostly in the lower extremities and the buttocks. Okay, and many of the times the adults, or you sorry no, the males, because it's more common in males, you will found that they have edema and scrotal swelling as well. Okay, So this is how HSP looks like, right? This is about the skin rash. So a palpable purpura of the lower limb and the buttocks. Now they also present with joint swelling, with arthritis and arthralgias, and in GIT, because the small vessels are inflamed over there as well. So they present with abdominal pain. They present with very few times GIT bleeding, and one of the thing also associated with intussusception. Okay, so these are the features, how they present with. So all these things. Now guys, one of the thing which is not written over here, but see that immune complexes which are circulating in the blood. Okay, I told you this is also called as IgA vasculitis. IgA vasculitis. So now, if you know that there is something called as IgA nephropathy. Now, see what happens, by the way, that immune complexes which are circulating in the blood, okay, what happens, like those circulating immune complexes, they will go and they will damage the kidney, or they get deposited in the kidney, so they have renal manifestations as well. How they will present? They present with hematuria, okay, nephritic syndrome. They have IgA nephropathy. They present with proteinuria, okay. They present with hypertension. They may have renal failure, but in very few of the patients, okay. So I think like you understand this condition, and how we diagnose them and how we treat them. Now see, uh, diagnosis, guys, in this condition, okay. I would rather take one thing, that's why I told you the topics are very small, so the lecture will be short as well. Okay, so I will write rather diagnosis and management, right? Okay, so in diagnosis point, see, remember one of the thing, guys, remember the clinical history. Okay, what is the clinical history? You will found that they have upper respiratory tract infection or a history of infection before some time, 1 to 3 weeks, with a classic triad, right? Rest of the blood tests you will do is what? You can go for CBC, you can go for ESR and CRP, okay? Of course, like they will be raised as well. And of course, like you already had the clinical picture and physical examination, clinical history and features. I would write like you will found that purpuric rash, okay, and all this stuff. So of course, like what you can found is a very important thing, renal function test, okay. So the renal function test, you can found like there could be hematuria, urine analysis, okay, you can do to check for hematuria and proteinuria and stuff like this, right? Now one of the thing, see, we can do skin biopsy of the lesion, okay, which will show the deposition of IgA and C3, okay, very important, right? And nowadays, like there is immunofluorescence techniques. They can I can show you over here, skin biopsy, okay, skin pathology or biopsy, you can see. So see, they can do this immunofluorescence test and they can see like there is deposition of IgA as well as C3, right? So you can check for these things. Other than that, what you can do is, depending on how the thing is going, for example, if the person is intussusception, you will go for ultrasonography and all the stuff, or you can find out simply how the patient is progressing, okay. So the diagnosis is done by this thing. Now one of the thing, like in management, guys, basically management is mainly supportive. Why? Because remember, it is the problem is with the immunity, right? It is the immune complexes which are circulating in the body. Of course, the patient will be presenting with joint pains and all this stuff, so you will give them anti-inflammatory drugs, which is symptomatic treatment, of course. Okay, you can give them this thing. You can give them corticosteroids. Makes sense, right? Because whenever, like, remember, it is mostly like immune related things, we go for suppressing the immunity of the patient, of course. And if, for example, if these things are not working, then we can go for immunosuppressive therapy as well, right? So now, like all this immunosuppressive drugs can be used. Now, all these things, like this is these decisions are made on the condition of the patient. Like, remember, guys, it's a self-limiting condition, number one. Okay, it's a self-limiting disease or condition. So most of the time, like, it resolves within 4 weeks. Okay, within 4 weeks time. So that's why you can say, like, most of the time we don't need these treatments, right? But in some of the patients, for example, 5% of the patients can go into renal failure. Okay, like the one who develop renal symptoms. So of course, like, they go into renal failure. So immunosuppressive drugs is mostly given when the children, or the child, they develop the renal condition. Then we go for immunosuppressive drugs. Okay, or sometimes, for example, if the child is going into renal failure, so maybe you will go for dialysis, right, for renal failure. For example, if the child has developed a chronic, for example, hypertension, you are going to treat the hypertension. So the things goes like in this way, right? You have to treat how the patient is presenting with, right? So simply, so uh, all these things, right, can be done. So this is about Henoch, schonlein, purpura, and the last thing which I'm going to discuss is Kawasaki disease, right? Now, Kawasaki disease is again a very, you can say, interesting type of disease, and I will tell you, like, why. Because it's a vasculitis, it's a type of vasculitis, and that's why I'm including this one in this lecture. Uh, Easy to remember. I would tell you how it is easy to remember, because there are many mnemonics to remember this condition. Okay, now, again, what are the similarities between Kawasaki disease and HSP? Number one, it is also acute vasculitis, okay, of unknown etiology. Now, this is, of course, the difference. Okay, it is also likely triggered by infection, right? Now, see, HSP, surely you will get a sign or a history of a previous infection, either clinical or subclinical, but this one is likely, you can say, triggered by infection. Now, the important thing about Kawasaki disease, it's a vasculitis. One thing is clear, or you can say it's a medium-sized vasculitis, right? With predilection of coronary arteries. Now, this is the most important point. Whenever, like, this vasculitis affect the coronary arteries, and that's why it is dangerous. And why I'm teaching you this thing, because it is the most common cause of acquired heart disease in children in developed countries. Okay, why developed countries? Because remember, guys, in developing countries, it's the rheumatic fever which gives this thing. So in developed countries, it's the Kawasaki disease which gives, okay, this one. So the peak age is 3 months to 5 years of age. It is more common in Asians, okay, and then comes the Caucasians, okay. So this is like the general introduction about this condition. Now I will tell you the diagnostic criteria of this condition. Okay. Okay. Diagnostic criteria. Okay. Now I will write down here. See, diagnostic criteria. Diagnostic criteria of Kawasaki disease, right? Okay, and you will found a lot of mnemonics, right? Okay, rather I would write mnemonics, mnemonics. Okay, okay. You will found, see, for example, rather I'm going to include this thing in my slide. Okay, um, okay, I will include this one in my slide as well. Okay, why? Because I told you they are very commonly present. Okay, now I'm going to include these things in my slide, the diagnostic criteria, like which I talk about, like the mnemonics, and of course, like whatever you like, you can remember. See, one thing is crash and burn. Okay, okay, not a very good criteria, but you can say a good criteria. But okay, I'm going to include one more criteria here as well, like this one, right? Okay, what is this criteria? This is cream, CREAM. I would rather recommend you to remember this one. See, crash and burn or cream, whatever you will remember. Now, what is the diagnostic criteria? You can remember it by warm cream, WARM, warm cream. What is warm? See what's written over here, fever for greater than 5 days. So guys, remember, fever for greater than 5 days with 4 out of 5 of these. So we need fever for greater than 5 days, number one. Number second, we need one of, I would rather enlarge it. We need 4 out of these 5 criteria. C is for conjunctivitis. R is for rash. E is for edema. A is for adenopathy. M is for mucosal involvement. Now guys, I will tell you now. Now I will include one more thing here to explain you how the disease behave. But before that, or before going into detailed explanation, I would rather talk about the clinical features. Guys, number one thing is fever. Fever. One of the things is what? Fever for more than 5 days, right? After that, cream, C for conjunctivitis. So they have bilateral non-exudative, like there is no exudation conjunctivitis. You can see over here. Okay. One thing is this thing, right? Second thing is what? They have rash. Okay. Okay. Let me open the rash of this one. Okay. Now, guys, to talk about the rash they have, basically they have fissured. Okay, they have polymorphous rash. Okay, they have polymorphous rash. Polymorphous rash means what? You can see over here different type of rash, right? Now E is for edema, right? E is for edema. Now I will tell you how the edema looks like. See, basically they have edema of the hand. See the swollen hand. They have edema of the feet. Okay, they have edema of the hands. They have edema of the feet. Okay, so this is how they present. Plus, they have subungual desquamation. The skin started falling off from around the nails. Okay, I will show you that thing. Subungual desquamation. See, the skin is falling off, right? Now, one of the things, guys, I will tell you, they have oral mucosal changings as well. Like, I will show you how it looks like, Basically, what they have strawberry tongue. Their tongue looks like strawberry because it is inflamed. Okay. They have fissured lips. See, you can see, very good photograph. Fissured lips with strawberry tongue. See, the tongue looks like strawberry. Okay. And if you will see their pharynx, it is also inflamed, right? So see, C is for conjunctivitis, done. I told you how it looks like, non-exudative. R is for rash. I told you how it looks like. E is for edema or erythema. Okay, so I told you erythema, redness, strawberry tongue, fissured lips, and all the stuff. Now they have cervical lymphadenopathy. A is for adenopathy, so they have cervical lymphadenopathy. Okay, so see how it looks like. See, now their lymph node get involved. It is usually unilateral. You can see like this one is fine. So unilateral lymph node is enlarged, and the diameter of this lymph node will be more than 1.5 centimeter. Quite big, you can say, right? You can see over here, or you can see over here. Okay, here it is not seen, but you can see like inflamed conjunctivitis. Okay, you can see over here. Unilateral cervical lymphadenopathy greater than 1.5 centimeter. And last is M for mucosal involvement. I told you, I show you how the mucous membranes look like. Okay, mucosal involvement. I will show you again. Involvement. Okay. So see, their mucous membranes are involved. See, inflamed mucous membranes. Okay, inflamed hands, palms of the hands. So this is how Kawasaki disease looks like. Now, why I include this one, guys, here? See, guys, fever, first week, second week, third week, fourth week, second week. I wanted to show you how this condition behaves. The fever starts. It is for more than 5 days. So see, first week and second week and maybe third week, just coming down. We need four of the 5 features. So as soon as the fever start, the conjunctival, they becomes conjunctivitis is there. Mucous membrane changes like pharyngeal injection, red, dry, cracked lips, and strawberry tongue. It goes with conjunctivitis. Cervical lymphadenopathy present. These 3 features are same. The rash started developing at the end of first week and goes up to third week. Extremities like edematous hand and feet, it also start at the end of first week and goes like this one. But why I'm showing you this thing, guys, is for this thing, complications. After second week, they started developing complications like cardiovascular signs like gallop rhythm, myocarditis, pericarditis, coronary and peripheral aneurysms they can develop. So that's the reason, guys. Now, this is the best, you can say, picture which I can get to explain you Kawasaki disease. See, Kawasaki disease is a diagnosis of exclusion. Understand? So you must exclude measles, scarlet fever, or anything which looks like this. Number 1. Number 2, we go for investigation. So see, CBC, white blood cells will be raised. ESR therapy will be raised. It will be mostly neutrophils. The platelets will be raised. Okay. But Kawasaki disease is a diagnosis of exclusion. We diagnose it by this one. It's a clinical diagnosis. So the diagnosis will be made clinically. If you found fever of greater than 5 days and 4 out of 5, these 5 features, the diagnosis is done. Okay, there is one condition which is called as atypical Kawasaki disease. For example, if there is fever for more than 5 days, but there is 2 to 3 criteria are met, not 4, we call it as atypical Kawasaki disease. In that one, we go for further investigations. Okay, understand? That is called as atypical Kawasaki disease. Okay, guys. Now, how we manage this condition? Okay, see, at the end of second month, what they are written over here, you need to do echocardiogram. Why? Because you have to see either they have developed any complications or not, like aneurysms. Now, guys, I will tell you the management of this condition. Now, how we manage this condition? As soon as the diagnosis of Kawasaki disease is met or is done, it is of unknown etiology. We started giving them intravenous immunoglobulins. Okay, with it is the only condition in which we give aspirin or aminosalicylic acid. Okay, aspirin to the babies. Otherwise, we don't use them. Why? Because the babies can develop Rice syndrome. Okay, guys, and we give them high dosages because in this one the benefits outweighs the risk. It is the only condition in which we give aspirin in high dosages to suppress that or to counter that inflammatory changes. So these are the two treatments we give them. For how long you have to give them? Wait for the patient to become afebrile. Okay. For more than 48 hours. Keep on giving this thing until the baby become afebrile for more than 48 hours. Once this thing is done, okay, then we give them low dose aspirin or ASA, acetylsalicylic acid, right? Now, how long you have to start this thing? Okay, start them with this thing, right? This thing. How long you have to give them this thing? Until platelets normalize. Okay. So we start them with this thing until they become afebrile for more than 48 hours. Once this thing is done, we decrease the dosage of aspirin until the platelets normalize. This is the main management, right? So why we give them intravenous immunoglobulins is simply because, when we start them with this thing, this shows like they have decreased risk of cardiac aneurysms or decreased risk of cardiac complications. Okay. And then, once this thing is done, like we keep on doing them their echocardiogram, okay, periodically, like time by time, okay, usually at 2 weeks and 6 weeks, just to see like for any cardiac aneurysms, right? If they have developed any cardiac aneurysms. Now, guys, you can see this one. This is a case history taken from a textbook of pediatrics. This 2-year-old boy developed a high-grade fever of 2 days duration. Examination showed a miserable child with mild conjunctivitis, a rash, and a cervical lymphadenopathy. A viral infection was diagnosed and his mother was reassured when he presented to the hospital 3 days later. Now the criteria is met. He was noted to have cracked lips. He was admitted. A full septic screen, including a lumbar puncture, was performed and antibiotics started. The following day, he was still febrile and irritable. His C-reactive protein had risen to 135, ESR to 125. Kawasaki disease was suspected and he was treated with intravenous immunoglobulins and high-dose oral aspirin. His clinical condition improved and he became febrile the following morning. An echocardiogram at this stage showed no aneurysms of the coronary arteries, which are the most serious complications associated with delayed diagnosis and treatment. On the 15th day of the illness, there was peeling of the fingers and toes. You can see over here. They have shown. Okay. So this is like just a case scenario, guys, to show you guys, how this condition looks like, how this condition behave. Okay, so what are the complications of this condition? Complications of this conditions is number one, coronary artery vasculitis. It is right. Okay, with aneurysm formation. Okay, it occurs in 20 to 25% of untreated patients, children. Okay, or when we start them with IV immunoglobulins, uh, the complication of this type of complication, the chances decrease too much. Okay, when they develop aneurysms, 50% of aneurysms regress of within 2 years. Okay, so this thing. So the risk factors of this coronary condition is increased when it's a male, it's a boy, the age is less than 1 year of age, or either it's more than 9 years of age, or if the fever is like more than 10 days, or if it like someone is of Asian ethnicity, or someone who is developing thrombocytopenia or hypopatremia, the chances of this thing is they're like are more. So this is about Kawasaki disease, guys. I hope you understand. Okay, and that's all for pediatrics. And I will see you soon. Okay, thank you so much for listening.